network education meeting. I'm Amy, and I'm one of the members of the steering group with the network. And we're really lucky to have Dr. Lauren Ha here today, staying up late for us to give us a talk about some of the work that she's been doing in Australia. Lauren is an accredited exercise physiologist and postdoctoral research fellow at the Behavioural Sciences Unit in Sydney at the University of New South Wales, and also with the Kids Cancer Centre at the Sydney Children's Hospital. Her work is funded by the Kids Cancer Project, and she is the project lead of an ongoing program that focuses on breaking down barriers experienced by childhood cancer survivors and their families in accessing physical activity support. So a big welcome, Lauren. Really, really grateful to have you here, and the floor is yours.
Thanks so much, Amy, and thanks everyone for having me today. I'm very excited to share my research with you. As an exercise physiologist, my research stems from my interest in improving physical activity behaviours, specifically in young people affected by childhood cancer. And most of my research also has a focus on using digital health and a person-centered approach where survivors' voices are elevated and being authentically heard and included in the research process. So I'd like to begin by acknowledging the traditional owners of the land on which I am working from today, the Gadigal people of the Eora Nation, and I'd also like to pay my respects to elders past and present, and any Indigenous people who are in this meeting today. Starting with a bit of background, I'm sure all aware that there are approximately 1,000 children diagnosed with cancer each year in Australia. As I conduct my research in Australia, the context is specific to Australia, but a lot of my research might be applicable to other countries as well. So 1,000 children are roughly diagnosed with cancer each year, and over 85% will survive their disease. And this is due to a number of contributors, such as advances in treatment, recognition of late effects, and also improvements in supportive care. However, despite these high survival rates, this population, or high survival rates in Australia and other high-income countries or other countries that have access to these treatments, this population are also exposed to harsh treatments at a young age, and this places them at an increased risk for a broad range of chronic health conditions as they age when compared to the general population or to their siblings. 60% will become overweight as a child or adult. They are also up to 15 times higher risk of developing cardiometabolic complications and 2 times higher risk of developing mental health problems. In the general population, engaging in physical activity are really important for reducing the risk of developing acute and chronic illnesses. Physical activity is a patient-modifiable factor where people can potentially influence their survival outcomes. Globally, physical inactivity has been recognized by the World Health Organization as a global pandemic. And being physically inactive has a significant cost to the health system and broader economy, not just in Australia, but worldwide. In 2013, in a study published in The Lancet, they found that the effect of physical inactivity has cost the world economy more than $67 billion through healthcare expenditure and productivity losses. And so within childhood cancer, we know that physical activity, there are some benefits of physical activity that have been shown in observational studies and a growing number of RCTs. These benefits extend from physical benefits such as improvements in functional mobility, muscular strength, bone health, to psychosocial benefits such as reductions in symptoms of depression and anxiety, as well as improvements in quality of life. Recently, or a few years ago, the International Pediatric Oncology Exercise Guidelines were published. And this was a consensus from a number of pediatric oncology and exercise experts based on the current evidence that we have. These recommendations and guidelines are quite broad and very general, and that's based on the preliminary research in childhood cancer and exercise. But based on what we have so far, we know that any child or adolescent diagnosed with cancer should choose to move, do what they can, and do it when they can. And that movement is possible and important for every child across all ages, abilities, diagnoses, stages, and phases, and across all settings, whether that's in hospital, at school, or within the community. And that line down there I wanted to highlight is that movement might look and feel different day to day, and that is okay. Hopefully in a few years' time, these guidelines will be updated to something more specific. But for now, we know that physical activity is safe in this population and is recommended. Despite the known risk of some of the late effects, such as increased risk in cardiovascular disease and obesity, and the potential benefits of physical activity, many childhood cancer survivors do not meet recommended guidelines. I assessed physical activity using gold standard measure of accelerometry over 7 consecutive days in 37 childhood cancer survivors aged 8 to 18 years old. And we found that 86% did not meet recommended guidelines of at least 60 minutes of moderate to vigorous physical activity per day, or MVPA. On average, they were engaging in 36 minutes of MVPA, and over the week, they were engaging in only 1 day of 60 minutes. Further to this, a lot of studies often only measure and quantify how many minutes of physical activity people are participating in. But few studies have utilized the richness of the accelerometry data that you can get from measuring over a 24-hour period. And by looking at that data a bit closely, you can detect information such as how MVPA might be accumulated, as well as the patterns of their physical activity and any behavior change. And this is called cluster analysis, which is a technique where you can group very large data sets into similar clusters, which are also different from other clusters. And using this technique and looking at this accelerometry data, which I measured 7 days of 24 hours in 37 participants, we found 4 main clusters. So cluster 1 being the really active cluster, so those participants who were generally very active. Cluster 2, they engaged in occasional bouts of MVPA, so very short bouts of at least 3 seconds, so it's very quick. Cluster 3 was minimal MVPA and very brief bouts of sedentary behavior. And cluster 4 was the highly sedentary group. And visually, you can look at the distribution of these different clusters over an hourly period, and you can also look at it over a typical week as well. The graph on the left is over a weekday, and the graph on the right is a weekend day. So the black bars show cluster 1, the light grey ones cluster 2, the darker grey, cluster 3, and the top bars there are the sedentary, the cluster 4. Just looking at it briefly, you can see that the most active days of the time are at 1 o'clock and in that afternoon period. So that suggests lunchtime at school and that after school period for those who are usually very active. And the highest sedentary areas were on the weekends, in the morning and in the afternoon. Overall, most participants were in cluster 2 and 3, where they would do very small amounts of MVPA with high amounts of sedentary behavior. So using that technique, not only did we find that survivors were engaging in low levels of physical activity, that they were only engaging in 1 day of the recommended guidelines, but how they actually engage in physical activity is that they do it in very short bouts. And they're also sandwiched in between very long bouts of sedentary behavior, especially on weekends. And despite this population's physical activity behaviors being similar to those without cancer, it's even more important for childhood cancer survivors to engage in physical activity because they are at that much higher risk of developing treatment-related health conditions. And so rather than just focusing on current guidelines of achieving 60 minutes of MVPA per day, perhaps recommendations in the future can shift to being something that's more specific, that's targeted to this population, such as increasing small bouts of MVPA, such as after school, decreasing those really long periods of sedentary behaviors as seen on weekends, and increasing that light intensity activity, which is especially important to start off with for a population who are already mostly sedentary. It's not realistic to expect them to just start exercising at a high intensity when they haven't been as active. And so this technique that I've used not only quantifies MVPA, but also captures really specific information about the time, length, and frequency of physical activity. I was also interested in how survivors perceive their physical activity. So we know that many have low physical activity levels, but having inaccurate or accurate perceptions about yourself might be a barrier to them wanting to increase physical activity levels. And so I compared their physical activity levels to how they perceived how active they were. So we asked them if they should be doing more physical activity or if they were doing the right amount. So here on the x-axis is their physical activity levels, and on the y is their perception. That dotted line represents the recommended guidelines of 420 minutes per week. Overall, we found that over 1/3 of survivors had inaccurate perceptions about their physical activity levels. So they either overestimated or they underestimated, which could be just another barrier that they face. And this is especially significant in the context that many survivors, especially in Australia, do not actually see an exercise professional. So they don't get tested. And so if they're not tested, how would they actually know if they're doing the right amount or should be doing more? Parents are also an important contributor. Many parents are the gateway to supporting kids in increasing their physical activity levels. And so I was also interested in how parents perceive their own physical activity, as well as the importance of their child exercising after cancer treatment. nearly all parents highly valued the importance of their child to be physically active. And sorry, this was in 125 parent survivor dyads. So most parents highly valued the importance for their child being physically active after cancer treatment. And from our regression model, we found that parents were more likely to perceive that their child should increase physical activity levels if they were older at the time of study, and if they had a higher body fat percentage. Interestingly, the child's own physical activity levels didn't appear to influence how parents perceived whether their child should engage in more physical activity. But these results suggest that parents might perceive their child's adiposity as a cue to increase physical activity levels. And so this really highlights a subgroup of survivors who might be overlooked in terms of their parents' focus on physical activity. So it's possible that those survivors who are sedentary but have a low body fat percentage might be missed because they might not appear to need more physical activity. And so this really highlights the importance of education, not only for the survivor in ensuring they've got accurate perceptions about their physical activity, but also to parents as well, so that they are aware of the importance of physical activity for all children, no matter their body type. And that will be important to breaking some of those barriers. We were also interested in whether parents had any concerns for their child exercising after cancer treatment. Parents' concerns were multifactorial, so they reported more than one concern. And even though about 20%, or even though 80% did not report exercise concerns, there's still a small percentage who do. And as you can see, a lot of these concerns, nearly all of them, can be addressed by an exercise professional in survivorship care. And so that's something that's really important to include. That's not standard of care. And so I guess my point is that there's so many barriers to physical activity for this population. They're complex, they're multifaceted. Survivors not only experience those physical barriers that we commonly know about, such as fatigue, their exercise capacity, their muscular strength, but also other barriers that might not be thought of, such as their perceptions about themselves, a lack of clear guidelines, a lack of education or limited education or limited age-appropriate resources, both for the child and the parent. Survivors also spend a long time in hospital. And so spending long periods of time in hospital or at home may lead to an increase or increased sedentary behaviors, and that in turn might lead to missed physical activity and social opportunities as well. As I alluded to before, there's a lack of exercise professionals embedded within survivorship care in Australia. And within Australia, we also have a unique barrier where we have very few pediatric hospitals because of the size of our country. And so this means that families are dispersed all over. And so in Australia, we're a huge country, and I've overlaid Europe on top. So you can see just how vast the country is. For example, the distance between Darwin, which is at the top end, to Perth, out in Western Australia, is over 4,000 kilometres. Based in Sydney, where I'm from, on the East Coast, to Brizzy, which is kind of the next closest major city is nearly 1,000 kilometers. So we've got long distances, which means families are coming from all over, and often they might have to take a plane or completely relocate. If we zoom into New South Wales, which is where I'm from, I'm in Sydney, and we only have 3 paediatric hospitals within the state. So we have one in Sydney, we have one up north on the Central Coast, and we have one out west as well. But you can see they're all concentrated together. And so families coming from out west, such as Broken Hill or Wagga Wagga, are having to really travel far distances just to get to a hospital. And so because of this massive barrier, it's what led me to investigate digital health. And so I was interested in whether a digital program was feasible to deliver and accepted by survivors. And I had a really great opportunity to collaborate with an industry partner who already had this app available, which was targeted for children without cancer in school. And I adapted this program to make it suitable for survivors to use at home. And in this program, it included 10 self-guided educational lessons about health, physical activity, and we also had 1 lesson on there about sugar-sweetened beverage intake. The program was connected to a wearable activity tracker, so that one you see on the screen. And the program really focused on monitoring their step counts and creating step goals to then increase their step counts. So this program was called iEngage. And for my pilot study, I recruited childhood cancer survivors who had completed cancer treatment at least 12 months prior and who were aged 8 to 13 years old. Primary outcomes were feasibility and acceptability. And I also assessed their physical activity levels, aerobic fitness, and their health-related quality of life. I also assessed their sugar-sweetened beverage intake, specifically about fruit juice and soft drink. And so we recruited 30 participants. Mean age was 12, and nearly half were diagnosed with acute lymphoblastic leukemia. Over this 12-week program, we found that this online program, or this digital app, was feasible. We had good retention rate, good module completion, and a high activity tracker compliance. And we also received some really great feedback, specifically about the education side of it and monitoring their physical activity. Specifically, we also found that many aspects of this program were deemed as their favorites. So doing activities with parents. So I adapted the program to include physical activities that involved them and their parents that they can do at home. And other highly rated components of the intervention were them being able to see their steps and learning about nutrition, as well as some of those activities on there. Something that was rated lower was using the tablet or the iPad and using the activity tracker. And this mainly was because the activity tracker didn't have a screen on it. And so what they had to do was they had to synchronize the activity tracker to the app in order to see their steps. And so that extra step was seen as something that was quite frustrating for the kids, because if they're exercising at school, they'd have to wait until they were home to then sync the data onto the program. We found that there was an increase in their aerobic fitness after they completed the intervention. This was not sustained at the 3-month follow-up, which might suggest we need perhaps a booster session in there. For health-related quality of life, we didn't see a significant improvement, but their quality of life was rated quite high in the first place. So overall, we found that this digital physical activity program is feasible, it's acceptable, and it's potentially effective in improving aerobic fitness. It provides an opportunity for education and engagement in physical activity, especially for those especially wherever you live. So it promotes physical activity for families living not only in local areas, but in regional and remote areas too. Having piloted this data, I had a lot of learnings, and something I wanted to talk about is considerations in working in that app space. We received low acceptability scores for the activity tracker and the tablet. The activity tracker, perhaps it was that lack of screen and that extra step of synchronizing their data. Tablet, I was unsure about this and something that I was really interested in exploring further. But the app itself, so back, if I'm just taking the learnings from me and not the participants, it was quite costly to maintain the app. So my collaboration with the industry partner, they had already gifted me in kind $200,000 of support, which was incredible. But for me to maintain and update or create changes to the app was going to cost a lot more. So for example, the app didn't have a back button. And this was frustrating because some kids would click next, 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 and then they'd want to go back because they missed what they read, but they couldn't do that. And to implement a back button was going to cost $100,000. So it was going to cost a lot, and it was money that I didn't have and don't have. And as well as that, changing the educational content on there for future iterations was also going to be a bit of a process. And so these days when apps are so good and so seamless, and something as basic as a back button is kids are used to that. And so if you're not creating a program or an app that is as seamless as what we get commercially, I think it can be really challenging for some of those acceptability ratings and feasibility and sustainability as well. And so having experienced that, I really wanted to work with survivors, work with participants to understand, okay, what's the best way forward? Because I was by myself, I didn't have the answers. And so that's when I ventured into co-design. And this diagram really nicely captures what co-design is. You can have an idea, everybody can have an idea, and it can all be built very differently. But in the end, the user just wanted a very simple tree swing. And so this diagram really nicely represents the importance of working with end users or consumers, especially if they're the ones who are going to be using the program and they're the ones who are going to be affected by it. And so what is co-design or co-production? Design is person-centered. So you're creating it for people. You're designing it with people, and you're designing it from the bottom up. It's a pragmatic process. So in this situation, survivors are experts in their own domain, and by involving them, it can lead to better outcomes. And it can also lead to new perspectives and alternate ways of doing things. And I strongly believe that survivors have a right to participate in the design of interventions that impact them. And so I established a youth advisory board. We have 3 amazing consumers on the board, and they share the decision-making process with us. We pay them, we include them in every step. I wish I would have done this earlier, but that wasn't the case. But for my next to build on from my pilot program is where we included them in the development and the update of the program. And so what I first started with was to bring together both lived experience, lived expertise, and professional experience to learn from each other and to, I guess, make things better. And so I conducted some focus groups with childhood cancer survivors, parents, and healthcare and community professionals to explore what their experiences were, what their priorities and preferences are in using digital health to promote physical activity for childhood cancer survivors. And we also explored what their suggestions were for future digital health or physical activity interventions. So I don't have the sample size, but we had 9 survivors, 13 parents, and 17 healthcare professionals. And they all participated in focus groups on their own. So they weren't mixed. It was survivors together, parents together, and professionals together. And we found 4 core components that were identified as priorities of priorities to include in physical activity interventions, including education, both physical activity and nutrition. Survivors were especially interested in nutrition. Goal setting, they wanted to set goals, not just in physical activity, but generally. And they wanted to be able to view those goals and to continually track them. Peer and parent involvement, providing physical activities that involve both their friends and family, but that would depend on their age. So the older kids wanted their friends and the younger ones wanted their families. And lastly, health professional support. This was more so identified by parents and professionals who said that it was important for them to include that health professional in physical activity. Here are just some quotes that I included. So one survivor said they wanted the actual facts behind losing weight and staying healthy, not just stuff you are seeing on social media, because it's so different from someone that hasn't gone through trying to lose weight to someone that actually does have past medical issues. Someone else said, another survivor said, the big thing for them is actually having instructions and knowing what to do in terms of exercise. I know that when I started a couple of weeks ago at the gym, it was very hard to actually know what exercise to do and how to do them correctly. And then a nurse said when they're on treatment and feeling unwell and tired, it's kind of the last thing on their to-do list. So from my personal experience, I don't think as a nurse, I was very good at educating as to why exercise is important. Some intervention design suggestions. Participants said they wanted early intervention, something that was tailored and age appropriate, addresses both diet and exercise, and having some concise education delivery. I won't go through those quotes. But the next stage of including all of those priorities and preferences from all 3 groups, I then took those findings and brought that back to the youth advisory board. And then we started the process of workshops where we would plan, review, evaluate different prototypes, share ideas, and provide feedback. And this intervention development of updating our previous pilot to in making it a better program was guided by the self-determination theory, which essentially is about using intrinsic motivation to engage in a health behavior that's directed by their self-autonomy, their confidence, and their perceived support. And so that was after a number of workshops and focus groups and activities, we updated the program, and that's now called Making Moves. We've moved away from the app because it was too expensive, and it wasn't going to meet what we wanted to do and achieve. And websites these days are really great at including information in different ways, and also it allows you as a researcher to change up that information to make it sustainable. And so we have 8 different educational modules. So we reduced the number so that it would be more concise and short. We have bite-sized information. So survivors didn't want long pages of information. They wanted it short, and they wanted it presented in different ways, whether that be text or videos or top tips. And then at the end of each module, we have exercise videos. And these exercise videos are guided exercises that they can follow along to at home. And then I guess the biggest change was that survivors in our youth advisory board, the biggest thing was that we couldn't find something that was a one-size-fits all. Every person would have their own unique questions or impacts. And so they really wanted to speak to somebody. And so we've added on telehealth sessions with an accredited exercise physiologist. And so currently I'm undertaking a type 1 hybrid effectiveness implementation trial. That is essentially 2 trials in one, where I'm examining the effectiveness of making moves on survivors' physical activity self-efficacy, which is their confidence in being physically active. And the second part of the trial is implementation, where I'm exploring what the barriers and facilitators are to implementing making moves. And this will inform future adaptations and implementation strategies. So we're recruiting 8 to 21 childhood cancer survivors, and for the implementation trial, we are interviewing potential implementers. So those in community organizations, hospitals, clinics, any potential implementer who is interested in the program and who might be able to implement it themselves in their own organization. We've got a number of outcomes there, but essentially Making Moves goes for 8 weeks. And on top of that, we have those telehealth sessions before they start at the beginning, so in weeks 2 or 3, after the program, and then at follow-up 3-month and 6-month follow-up. Our preliminary results, I've just quickly done this, but we've already seen amazing results in improvements in their physical activity self-efficacy, their fitness and muscular strength. And from our interviews in the implementation, core barriers were lack of funding for exercise physiologists or limited staff to maintain that program. Facilitators were that there was great support for physical activity and alignment with organization missions and goals. And so this kind of has been my research program of work, starting from my pilot study to incorporating co-design to now implementing this trial and exploring other ways of how it can be implemented beyond the research context. with the ultimate goal of hopefully it being implemented after this study. And so next steps, still continuing with recruitment, but there's one community organisation who's really interested, and it seems like a really great fit. So I would love to test the community implementation of Making Moves. And we've also recently received some funding in Denmark to test this program over there as well. And yeah, that's it. Thanks for listening. Sorry, I know I've gone a little bit over time. But yeah, thank you for listening and happy to take any questions.
Thank you so much, Lauren. That was really, really insightful and such a really wonderful way to sort of demonstrate your journey of learning and sort of learning how to engage with our childhood cancer survivors in a really meaningful way, so that we design things that we know that they're going to use and that we know are going to be really helpful. Fabulous. If anyone's got any questions, please pop them in the chat, or you can just pop your hand up and start talking. I suppose with regards to Making Moves, is this a Australia-wide intervention, and sort of when you're thinking about your community organizations, you must have so many different people that you would be engaging with.
Yeah, so it is currently open to any survivor living in Australia. That's, I guess, the benefit of it being fully remote and delivered online. And the biggest thing, I guess, with when we were interviewing for implementation is that we needed an organization or a group that had that online capacity, who already had some sort of or who were willing to create almost a platform where they can hold this online program. And that was also a challenge for organizations who didn't have that but were really interested. But because it being online was such a core component, we reached so many rural and remote families. We really couldn't make it in person. So it really needed to be an organization that had that capacity to deliver it online themselves.
Yeah, it's such a big ask, isn't it? It's a and a significant consideration, because digital health is really the only way that we're going to be able to reach everybody, and sort of increase the sort of equitable access to support, particularly in the survivorship space, because we know that it's so severely underfunded globally. I wondered whether or not, thinking about bringing communities together, if you've got clusters of people in different communities, is there a thought that you could have on-site or in-person kind of components to create a sense of community?
Absolutely. And I love that you brought up equity, because there's also the sense that some families don't have access to online tools. And so for it to be truly equitable, we want a similar option that they can have access to, whether that being paper-based resources or, like you said, training some local communities so that they can deliver a program like this. That's definitely has been on my mind for the future of this, and looking at different ways of how we can either train already existing health professionals in delivering this, or thinking of another version of this program, whether it be paper-based or I'm not sure really.
You got to do it, it's got to be sequential and kind of make sense in terms of the processes to make sure that you get the best kind of combination. but just thinking about how rural and vast Australia is, having that sort of community level engagement
Yeah.
down the line would be really lovely.
Yeah, and it will be interesting to test it in Denmark because their country
Mm.
is really small. And so um, whether yeah, it's also feasible for them as well um, to do a program online because they don't have as many barriers of travel and distance as we do. So that will also be interesting, I think.
Mm. And that relationship with Denmark, how did that happen?
Yeah, it was very yeah, I emailed them. So Associate Professor Hannah Backard Larson, she does a lot of cool research in delivering physical activity interventions in this space. And I guess their biggest study, the RESPECT study, they have this really cool project where they have ambassadors or classmates come into the hospital and exercise with the survivor. And so they look at not only physical outcomes, but psychosocial outcomes. And I just emailed them one day and met them at a conference and then put in a grant together and got it. So I think it's yeah, it kind of just happened.
Oh, it's
But
really
yeah, that would
beautiful.
be
And
really
yeah, and some of them were at PSYOP recently, with I
yes.
think some of the Denmark group. Yeah, yeah, lovely. I mean, there's no point in reinventing the wheel in multiple
Exactly.
different countries, right? So
Mm.
obviously this is going to be available in other languages now.
Yes, so it will be in Danish, I guess. I've
Mm,
also put in a grant to test this in other languages here in Australia as well. But that's just dependent on grant funding. But that would be the plan to create, I think, a shorter version of this. And yeah, translate that and test that as well.
oh, wow, it's really wonderful, and it's so lovely to see the kind of vision that you've got. If anyone else got any questions, please feel free to ask away in the chat or just turn your microphone on. Otherwise, we can let Lauren go to bed. Well, I mean, I really look forward to watching how this goes for you, Lauren. It's a really positive thing to be involved in the survivorship space. And like we said when we met at the conference, nutrition and physical activity go so nicely together. So I think, yeah, collaborations, like you say, reaching out to people randomly sometimes really works. So
Yeah, it does.
yeah,
Yes. Email
so you got
that
to be
person.
bold and brave. Yeah.
Yeah.
Um,
Yeah, and I would also love to include more nutrition into the program. We only have one module, and that's on sugar sweetened beverage intake. So about
mm,
sugary drinks. And that's something that a lot of our participants really loved is to learn more about food. So there is that interest there.
mm,
And yeah, I would love to expand that to to include more
yeah.
nutrients.
Well, we've definitely got a bunch of people here that would no doubt love to be involved. And yeah, thank you so much once again. Thank you for staying up. I know it's late in
Thank
Australia.
you.
Just really wonderful thanks from the chat section as well. Just everyone really enjoying your presentation, Lauren. So yeah, really grateful. And yeah, we'll definitely be in touch. You have a
Thanks so
lovely
much.
evening
Thanks for having
and
me.
yeah, have a lovely day, everyone, as well.
Thank you.
Thank you,
Bye.
everyone. Thanks, Amy.
Bye.